All right, everyone, it's the top of the hour. I am Gabe Fontaine, and as you join us here today, please remember to mute your microphone. There will be time for question and answer sessions at the end of each of the presentations. And at that time, we'll ask you if you'd like to come off of mute and you can ask your questions verbally, or throughout the presentations, you can type them into the chat and we'll moderate those questions after each presentation. We have a couple of other moderators here today. We have Leslie Hamilton from the University of Tennessee Health Science Center, College of Pharmacy, and then also Kent Owusu at Yale New Haven Health. And we'd also like to shout out to Corinne Berger, our Journal Club coordinator, who's been doing a fantastic job getting our presenters and moderators on board for this. You can engage throughout the session today on Twitter using the hashtag NCSPharmJC for Journal Club. And then we'll get started here in just one moment. Our two speakers today will be Evan Sawyer, PGY2 Critical Care Pharmacy Resident from the Indiana University Health, and then also Taylor Wagaspak, PGY2 Critical Care Resident from Ochsner Medical Center. I'll allow each of them to introduce their own slides. And Evan, we can get started with you. Thank you so much, everyone. Enjoy the session.
Thank you, Gabe, for the introduction. Are you able to see my slides okay?
Yes, I can see those, Evan, and we can hear you great.
All right, perfect. All right, so as Gabe said, my name is Evan Sawyer. I am the PGY2 Critical Care Resident at Indiana University Health Academic Health Center, and I am very excited to present the results of the APACHE AF study today, or apixaban versus no anticoagulation after anticoagulation associated intracerebral hemorrhage in patients with atrial fibrillation in the Netherlands.
Recording in progress.
Have a couple of objectives for the presentation today. The first of which is to summarize the clinical problem and the existing evidence for restarting anticoagulation in patients with non-valvular atrial fibrillation after anticoag-associated ICHs. Then we'll dive into more of the specifics of the findings of the APACHE AF study. So the dilemma of restarting anticoagulation after intracerebral hemorrhage involves careful risk evaluations for hemorrhagic and ischemic processes, often of which are usually intertwined. Firstly, disease pathology, as well as the location of intracerebral hemorrhages, tend to dictate the likely rates of either rebleeding or having future ischemic events. On the right, we have a picture of a right thalamic ICH or a non-lobar ICH that are frequently associated with hypertensive bleeds and are located more in the deep brain. These are more likely to be associated with recurrent risk of ischemia, whereas on the left, we have pictures of more superficial lobar intracranial hemorrhages, which tend to be associated with pathologies such as cerebral amyloid angiopathy, which has much higher risk of rebleeding. Then finally, as we are aware, the CHADS-2 VAS score helps calculate annual stroke risk in patients with atrial fibrillation and is a useful metric when evaluating these patients. The results of all of these patient-specific factors and the risk-benefit calculations that go into each decision leads to significant variance in clinical practice. The next two slides will be presenting the results of a global survey of neurologists, neurosurgeons, and thrombosis experts and their preferences on when to restart anticoagulation based on the underlying pathology. On the left, we have cerebral amyloid angiopathy, as well as previous ICHs, where the majority of physicians either say that they would prefer to permanently discontinue anticoagulation, if not significantly delay it. Whereas on the right, patients with smaller volume bleeds, higher ischemic risk, or more provoked traumatic ICHs are more likely to be restarted on anticoagulation earlier. This same survey also asked providers their preferred anticoagulant of choice upon restarting anticoagulation. Most thrombosis experts and neurologists answered that they would prefer direct oral anticoagulants like apixaban and rivaroxaban upon restart, whereas the majority of neurosurgeons said that they would prefer either continuing the previous anticoagulant or starting patients on warfarin with a target INR of 2 to 3. Next, we'll quickly delve into the existing literature, including 2 retrospective observational studies. The first of which, by Kuramatsu et al., that came out in 2015, looked at 719 patients with anticoagulation-associated ICHs, of whom 172 resumed anticoagulation post-ICH. They found significantly reduced rates of ischemic events post-restarting oral anticoagulation compared to patients who were not restarted on oral anticoagulation, with a p-value of less than 0.001. They interestingly did not find an increased risk of rehemorrhage upon restarting anticoagulation. And they also conducted a propensity-matched long-term survival analysis, which found that the hazard ratio for mortality for restarting anticoagulation was 0.258, a significant difference. The authors of this study concluded the resumption of anticoagulation was associated with lower ischemic event rates. The next is the Biffy et al. Study, which was a meta-analysis of 3 different cohorts, including the Kuramatsu et al. Study. They dichotomized 1,012 patients by the location of the ICH, non-lobar or lobar, and they used a multivariate model assessing resuming oral anticoagulation based on the location. What they ultimately found was that regardless of location, non-lobar or lobar, resumption of oral anticoagulation was associated with decreased mortality, as well as increased likelihood of favorable functional outcomes, with odds ratio for functional outcomes being 4.22 and 4.08 respectively. This study also concluded that there's a need for randomized controlled trials to account for possible confounding or severity bias for patients who might have been resumed on oral anticoagulation because they were deemed lower risk. There have been 2 recent guideline statements, the first by the European Stroke Organization and the second being by the Canadian Stroke Best Practice Recommendations, that have recently suggested to reinitiate anticoagulation should be based on risk-benefit calculations and patient-specific factors. The Canadian Best Practice Recommendations also deemed that direct oral anticoagulants were preferred over warfarin upon restarting due to proven lower rates of ICH in atrial fibrillation patients without previous intracranial hemorrhages. Since the release of those guideline statements, findings of 2 randomized studies have been released, the first of which is the Apache AF study, which is why we're all here today, and the second being the SOSTART collaboration pilot study that also came out in Lancet Neurology last year. This was a multi-center non-inferiority study that randomized patients 1-to-1 to either receive oral anticoagulation or avoid oral anticoagulation. 203 patients were enrolled, and the primary outcome was the rates of recurrent symptomatic spontaneous intracranial hemorrhages within at least 1 year of follow-up. Patients were enrolled in this study at a median of 115 days post-ICH and followed for a median of 1.2 years. For the primary outcome of recurrent ICH, the rate was 8% in the oral anticoagulation group compared to 4% in the avoid group, a non-significant difference with a p-value of 0.152. The authors of this study determined that they were unable to determine if resumption of oral anticoagulation was non-inferior to avoiding it, and that adequately powered randomized trials were needed. So this brings us to the Apache AF study that we'll be discussing today. The authors of this study hypothesized that in patients with atrial fibrillation who survived an anticoag-associated ICH, treatment with apixaban might be a better long-term alternative to withholding it. The primary aim of this study was to inform sample size calculations for a necessary phase 3 clinical trial by reliably estimating the rates of the primary outcome, which was non-fatal stroke or vascular death. This was a phase 2, open label, randomized trial with blinded endpoint assessment conducted at 16 hospitals in the Netherlands. Patients were included if they had a spontaneous ICH, including isolated intraventricular hemorrhages and excluding patients with subdural hematomas, while they were on anticoagulation for non-valvular AFib. They had to be enrolled within 7 to 90 days post-ICH, have a baseline CHADS2 VAS score of at least 2, and a baseline modified Rankin scale score for functional status of less than or equal to 4. Patients were excluded if they had other indications for long-term anticoagulation, such as venous thromboembolisms, if they, regardless of assignment to the apixaban group, were going to be initiated or continued on an antiplatelet agent, if they were deemed to have a high risk of bleeding or had other serious bleeding events recently, had alcohol or drug misuse, poor long-term prognosis, significant renal impairment with creatinine clearance of less than 15, as well as significant liver impairment or the use of strong CYP3A4 inhibitors. And the final exclusion criteria was women who were pregnant, breastfeeding, or of childbearing potential. Patients were randomized 1-to-1 to either receive apixaban 5 milligrams twice daily with a dose reduction to 2.5 milligrams daily for creatinine clearance of 15 to 30, or for meeting 2 of the 3 criteria that I'm sure we're all familiar with per package labeling, or patients in the avoid anticoagulation group, once they were assigned to the control arm, could be started on an antiplatelet agent at the discretion of the supervising physician. The options for the accepted antiplatelet agents are listed here on the slide. And for follow-up, patients were followed at 1, 6, and 12 months, and then at least every 12 months until the end of the study. Patients were expected to be followed for at least 6 months in order to be included. For the selected outcomes of the study, as I mentioned, the primary outcome was the rate of non-fatal stroke, including ischemic intracranial hemorrhages and subarachnoid hemorrhages, or vascular death during the follow-up period. Secondary outcomes, as listed on the slide here, included various types of intra and extracranial bleeding, the rates of stroke, myocardial infarction, systemic and pulmonary embolisms, as well as vascular death and all-cause death. For the statistical analysis, the power calculation estimated that following patients for 100 patient years per group would yield a 95% confidence interval predicting 4.9 to 17.6 events based on previous literature. A Kaplan-Meier analysis of the time to the first primary outcome event was also conducted. And for secondary outcomes and composite outcomes, these outcomes were presented with both crude and adjusted hazard ratios, of which were conducted using Cox regression analyses with time-varying covariates. An as-treated secondary analysis based on the modified Rankin scale score, as well as based on the time spent on anticoagulation, were calculated. These were the only as-treated analyses that were conducted during the study. And for subgroups, there were several different pre-specified subgroups, which are listed here in the slide, and we'll be revisiting later in the results section. So here we have the enrollment characteristics for the two different groups. 101 patients total were enrolled, split 1-to-1 between the apixaban and avoid anticoagulation groups. In the apixaban group, there were 4 patients who did not start treatment and 5 patients who discontinued treatment during the period of follow-up. However, all 50 patients were included in the intention to treat analysis. In the avoid anticoagulation group, there were 11 patients who ultimately crossed over to being anticoagulated during the follow-up period, 3 of whom had ischemic strokes and 4 of whom had pulmonary embolisms. Next, with the time we have, I'd like to quickly kind of touch through some of the different baseline characteristics for the patients who were included in this trial. Starting with the age of the patients who are included, the median age was about 78 years old. There was significant ethnic homogeneity with regards to the patients who were included, as 99% of the patients were white. Next, the CHADS-2 VAS scores were evenly distributed between the two groups, with medians of 4 in each group. And with regards to the specific oral anticoagulant that led to the initial ICH, about 2/3 of the patients in each group were on a vitamin K antagonist prior to their initial ICH. Not listed on this slide, but relative to the overall characteristics of the study, were that patients were followed for a median of 1.9 years, and there were a total of 222 person years that were included within the results of the study. For the baseline characteristics, the locations of the ICHs were evenly distributed between the two groups, with about 1/4 of the patients having lobar hemorrhages, about half the patients having deep brain hemorrhages. Patients were enrolled with a median of 45 and 46 days post-ICH, respectively, with interquartile ranges roughly being between 20 and 75 days. Blood pressures were roughly even at baseline between the two different groups. And then finally, the one slight difference between the two different groups at baseline was the modified Rankin scale score at randomization, as demonstrated here in the stat bar graph, with the modified Rankin scale score being slightly higher in the avoid group, suggesting that they might have had a slightly lower baseline functional status relative to the anticoagulated group. For the primary outcome of non-fatal stroke or vascular death, this occurred in 26% of the apixaban patients compared to 24% of the avoid patients, a non-statistically significant difference with p-values in the unadjusted and adjusted analyses of 0.87 and 0.9 respectively. Moving on to secondary outcomes, intracerebral hemorrhage occurred in 8% of the apixaban patients compared to 2% of the avoid patients, a statistically non-significant difference with hazard ratios of 4.12 and 4.08 respectively, and p-values of 0.21. There were also no statistical differences between all major hemorrhagic events between the two groups, occurring in 12% and 6% respectively. Ischemic strokes occurred in 12% of the patients in both groups. Continuing on with secondary outcomes, all major occlusive events, including systemic venous thromboembolisms, the rate in the apixaban group was 12% compared to 22% in the avoid group, a statistically non-significant difference following a pattern here with a p-value of 0.13. There were also no differences in the rates of all major vascular events at 28 versus 31%, and the final composite secondary outcome of myocardial infarction, stroke, or vascular death. Moving on to the secondary analysis, which was the effective treatment on the modified Rankin scale scores at each of the follow-up points. There were no statistically significant differences in the odds ratios for apixaban compared to the avoid anticoagulation group at the 6-month follow-up, the 12-month follow-up, of the 24-month follow-up. Moving on to the next slide, for the Kaplan-Meier analysis of the time to the first occurrence of the primary outcome event, which was non-fatal stroke or vascular death, there were no significant differences with the adjusted hazard ratio that was calculated of 1.05 for apixaban relative to the avoid group with a p-value of 0.9. And finally, the pre-specified subgroups that I mentioned previously are listed here in the forest plot and were conducted on the primary outcome of non-fatal stroke or vascular death. There were no significant differences detected in any of these subgroups that were displayed here, which included age greater than or less than 75 years old, as well as gender, time from the initial intracranial hemorrhage to randomization within the study, as well as the subgroup analysis based on the location of the ICH, the baseline CHADS2 VAS score, the decision to initiate or avoid an antiplatelet in the control arm, as well as the CT-based small vessel disease score. The authors of this study ultimately concluded that the results neither rule out the benefit of restarting anticoagulation in patients with atrial fibrillation post-ICH. They also noted that the high annual risk of non-fatal stroke or vascular death that was found in both groups within the study underscores the need for ongoing, larger randomized controlled trials. I'll briefly touch on my critique of the strengths and limitations of the study. Firstly, the decision to include patients within a window of 7 to 90 days post-initial ICH was a little bit more restricted and concise compared to some of the other prospective and retrospective analyses, and creates more of a homogeneous inclusion criteria. Additionally, the inclusion of only patients whose indication for anticoagulation was atrial fibrillation meant that they had a little bit more similar baseline vascular risk profiles. The decision to use just apixaban, a single direct oral anticoagulant, as compared to some of the previous retrospective analyses, which looked at all oral anticoagulation, was a little bit, perhaps would have been able to detect more of a treatment effect if there were one on a larger scale. And then finally, the duration of follow-up. I previously mentioned that patients were followed for a median of 1.9 years. So any ability to sort of calculate sort of the annual risk difference or even beyond that was potentially able to be detected given the duration of follow-up in this study. As noted, there were also some limitations which were to be expected given the overall design. With it being a phase 2 study, it wasn't entirely surprising that the smaller sample size of the study led to not finding conclusive results with regards to the primary outcome, as well as the secondary outcomes or the subgroups. And then secondly, in terms of external validity to other patient populations, the fact that 99% of the patients included were white could potentially limit that being applied to patients of other ethnicities. I want to quickly wrap up the next couple of slides here by kind of talking about the next step and the future directions within this exciting area of interest. There are currently 5 different ongoing randomized controlled trials evaluating these similar patient populations. The first 4 of which listed on the slide here are looking at patients specifically who had ICHs associated with atrial fibrillation and anticoagulation on that. The ENRICH-AF study is comparing the use of edoxaban to no anticoagulation in this group. The ASPIRE study is comparing the use of apixaban versus the use of aspirin. The PRESTIGE-AF study is looking at the use of any direct oral anticoagulant compared to the use of avoiding anticoagulation. The A3-ICH study is a 3-arm trial that is comparing the use of apixaban to the intervention of a left atrial appendage occlusion to neither intervention. And finally, the status trial, which is a little bit broader inclusion criteria, looking at ICH and any indication for anticoagulation, and having the intervention of any anticoagulation versus no anticoagulation. So just to wrap up sort of the findings and the clinical applicability of the trial, the Apache AF study was a phase 2 trial that found no differences between holding or restarting anticoagulation in atrial fibrillation post-ICH. The lack of a mortality benefit or mortality harm that was found in this study compared to the mortality association, reduced mortality association that was found with restarting anticoagulation in the retrospective observational studies, perhaps could slow down any thoughts of sort of tying the two together, and also highlights the need for continuing on with the larger randomized controlled trials that are ongoing. As for the application of the findings to clinical practice, it's slightly too soon to say at this point with regards to changing the overall direction of practice. Let's say continuing to weigh the risks and benefits on a patient-specific individual benefit is the best at this point, and await for results from these larger randomized trials that are ongoing, and will hopefully be changing practice here in the next couple of years. So I really appreciate your all's time in listening to this presentation. I'll be excited to answer any questions that you all have. Thanks.
Thanks so much, Evan. That was an excellent presentation. And thanks especially for the background, bringing us up to speed with the literature prior to conducting and publishing this study. There are a couple of questions that were just posted in the chat, and so I'll read those out loud. And then after these questions, we'll continue to monitor the chat. And if anyone would like to come off mute too, we can also do that. And you can just raise your hand and I'll call on you. So Mohammed has asked, what are your thoughts or considerations on restarting anticoagulation in patients with mechanical heart valves? So not specifically surrounding the patient population within this study, but maybe what are sort of your individualized risk benefit evaluations for patients with mechanical heart valves?
Yeah, so I think that's certainly an interesting question, and one that's been looked at a little bit less specifically in some of the retrospective analyses. As we're aware, the rates of ischemic risk, annual ischemic risk, can potentially go up with some of the mechanical heart valves. So they would potentially be leaning more towards initiating if possible. So I would say sort of the patient characteristics that fell to the right of the screen back in the survey that lended more towards patients being restarted on anticoagulation, such as smaller bleeds or potentially being caused by an isolated traumatic incident. If they have that sort of presentation and a mechanical heart valve, I certainly think that due to the higher rates of ischemic stroke that could occur with mechanical heart valves, I would be more likely to want to reinitiate that anticoagulation earlier. However, if they had a larger intracranial hemorrhage, had worse baseline prognosis, or had some of the more insidious pathologies that underlie the ICH, that could potentially still portend against early reinitiation of anticoagulation in those patients. Does that answer Joel's question?
Thanks, Evan. That was a very thoughtful answer and approach to evaluating those patients. There's a couple more questions here in the chat. First off, Kent reports from the Twitter poll that about half of the respondents selected a reinitiation timeframe of 14 to 90 days. That's when they would restart, 53% to be exact. 33% selected 7 to 14 days. And finally, 13% selected within 7 days. And then he follows it up with the question of, could you please comment on what you believe to be the optimal reinitiation time, let's say specifically for atrial fibrillation based on the presentation and data to date?
Yeah, absolutely. I think the lack of conclusive findings that we found in the prospective study makes it hard to kind of take a more broad approach to applying it to all the different patient populations. I think it kind of goes back to those patient-specific factors. So more of the risks of the rates of rebleeding, so larger, or the consequences of that. So larger hematomas, the more superficial lobar bleeds, in patients with more insidious underlying pathologies like cerebral amyloid angiopathies. I would still push against early initiation, but for patients without some of these more concerning factors for recurrent bleeds, I think, at least in practice, seen anywhere within the first 28 days, it seems like day 14 tends to be a tipping point in a lot of these patients. I think that continuing with sort of that approach makes sense to me, if that makes sense. So I wish that the answer choice of 14 to 90 days is kind of incredibly broad, but it does tend to see that, if we calculate ischemic risk on an annual stroke rate, that the difference between day 1 to day 2 might not be quite as much, but once you get beyond, a certain point, you're gonna start having increased frequency of events without reinitiating anticoagulation. So the 14-day tipping point would make sense for a lot of those patients.
That insight, Evan. We have 2 final questions, and then we'll get moved on to Taylor's presentation. Andy Webb asks, do you think DOAC anti-10A monitoring might have a role in these patients?
I think that's an excellent question, and one that I find particularly fascinating with regards to sort of assessing anticoagulation. At least the literature I'm familiar with, there tends to still be a little bit of a gap with regards to isolating specific target ranges for each of the DOACs and then applying that to practice. I know there are different retrospective analyses that have looked at certain anti-10A expected troughs based on the DOAC and sort of implementing that. So I would say there's not enough of a clinical correlation at this point, although it would be great if that clinical question could be answered to apply it to all patients at this point, but maybe those who I'd be more concerned about based on their kinetics. So obesity, liver dysfunction, renal dysfunction. I think certainly considering anti-10A monitoring would certainly jump to mind in those types of patients.
And the last question we have here, and you touched upon this a little bit in your presentation with the homogeneity of the patient population. How does the Netherlands population compare to the US population? And could this study, if done in an even larger population, be extrapolated, or is it relevant to the US population?
Yeah, that's certainly another excellent question. With regards to the different direct oral anticoagulants, I tend to think of more of the pharmacogenomics of the metabolism and the different sort of CYP metabolism patterns. I know that I've looked at with Xarelto, at least, in some of the primary prevention trials have kind of looked at different patient populations with certain pharmacogenomic parameters, such as less likely to metabolize or more likely to metabolize. I think it's something certainly to keep in mind, and I would be interested in the rates of the CYP polymorphisms in a population that's 99% white from the Netherlands. I would be a little bit cautious in applying that to patients here. Certainly of more broad genetic backgrounds, and then also potentially changes in the kinetics as well. So I don't recall any comments about sort of weight or average BMI or anything, but that's another thing I would think of.
Excellent. Thanks so much, Evan. Thanks for the very thorough presentation and your thoughtful responses, and thanks to all the members of the audience in these questions. Excellent. One final plug before moving on to Taylor's presentation. Often overlooked is VTE chemoprophylaxis, right, in the early initiation of that in these patients. And so it's not always necessary to go directly to therapeutic anticoagulation. We do have that sort of bridging period where they're still at high risk of venous thromboembolic disease. And so early initiation of appropriate chemoprophylaxis is necessary. Thanks so much, Evan. Next On the docket today, we have Taylor Wagaspak from Ochsner Medical Center. And Taylor, whenever you're able to, you can share your slides and get started.
Perfect, will do. Just give me one moment. Okay, are you guys able to see my screen?
Your screen and your volume is perfect.
Perfect. Thank you. Thank you for that introduction. Yes, my name is Taylor Wagaspak, and I'm currently a PGY2 critical care pharmacy resident at Ochsner Medical Center in New Orleans. Today, we're going to be reviewing the comparison of clofidipine and nicardipine for acute blood pressure reduction in the setting of a hemorrhagic stroke. Before we jump into the data, I first want to go over some statistics. So in 2018, stroke was ranked the 5th leading cause of death amongst all cardiovascular disease, and the global prevalence of stroke was about 102 million people. In 2019, acute ischemic strokes occurred most commonly, with only about 13% of the strokes occurring being hemorrhagic. Although hemorrhagic strokes account for a smaller portion of patients, it is associated with higher morbidity as well as higher mortality, as we see here in the pie chart on the right. So with that being said, today we're going to focus mainly on hemorrhagic strokes, in particular intracerebral and subarachnoid hemorrhages. So as a pharmacist in the neurocritical care unit, we all are well aware of the consequences that can occur in the setting of a hemorrhagic stroke. We all know what to look for, whether it be increased ICPs, or the potentiation for herniation. But most importantly, in that acute period, we want to make sure that we are looking at blood pressure management, and essentially in that 6 to 12 hour period, immediately following the bleed. So elevated blood pressure that frequently coincides with an ICH or subarachnoid hemorrhage can put a patient at risk for a further hematoma expansion or rebleeding. And the occurrence of these complications happening have been shown to lead to poor functional outcomes at 3 months post-bleed. So we do have guideline recommendations on blood pressure management in these patients. However, current guidelines recommend some blood pressure parameters or goals, but unfortunately they are supported by low quality evidence. So these recommendations provided by the guidelines, as well as current clinical practice, have incorporated a similar approach to blood pressure management in these patients, which is typically supported by the INTERACT-2 or ATTACH trials, which indicated a modestly better functional outcome in these patients and potentially less hematoma expansion. However, that was at the expense of no mortality benefit, as well as potentially an increased risk of renal injury. So keeping all of that in mind, it seems as though we really don't know the optimal blood pressure targets in this particular patient population. But since those guidelines were published, we have had 3 retrospective direct comparisons of nicardipine with clofidipine in patients with acute ischemic stroke as well as in hemorrhagic stroke. So first, we're going to start off with Finger and colleagues, and this was a retrospective review that was performed in 57 patients that were admitted to the neuro ICU that needed acute blood pressure lowering in the setting of a neurological injury. The type of neurological injury is what dictated the specific blood pressure targets that the providers were targeting. The majority of these patients did have an ICH, with only about 11% of them having an acute ischemic stroke. The other 50% of these patients had other neurological injuries, such as like a tumor resection or a seizure or hydrocephalus. Their primary outcome looked at the time it took to reach the specific blood pressure targets and the percentage of time that the patient was within that target blood pressure range. There was no statistically significant difference in acute blood pressure management between these 2 agents. However, they did have a trend towards a shorter amount of time to target SBP and significantly less volume administered in the clofidipine group. As you can see here in the table, the median time to target SBP was about 30 minutes in the clofidipine group versus 46 minutes in the nicardipine group. Next, we have Rosenfeld et al. they did a retrospective review that included 119 patients that presented with an acute ischemic stroke or an ICH or a subarachnoid hemorrhage. And again, this was in patients who needed acute blood pressure lowering presenting with one of these stroke types. So of note, the SBP goals in this trial were defined based on a case-by-case basis by the clinicians that were treating the patients. And the investigators here sought to determine the time to SBP goal at 1 hour and 6 hours after the infusion was started. They found no difference between the percentage of patients that achieved a target blood pressure goal within the 1 to 6 hour period of starting the medications. And the median time to target SBP goals here were very similar between the two groups. Overall, these authors concluded that both nicardipine and clofidipine are reasonable antihypertensive agents for stroke. And although cost and volume restrictions should differentiate the preference here, whether it be clofidipine versus nicardipine. And then lastly, we have Allison and colleagues that completed a retrospective observational study of 210 patients that were admitted to the ED for either acute ischemic stroke or ICH. 63% of these patients had an ICH and 37% of them had an acute ischemic stroke. These authors wanted to determine the time from onset to either agent to the blood pressure goal of either less than 180 in patients with acute ischemic stroke or less than 150 in patients with an ICH. They found that there was no difference in the mean time from initiation of the infusion to the goal SBP between the agents or in any of the secondary outcomes. So before moving on, I did want to briefly point out the fact that Rosenfeld was the only trial that commented on hematoma expansion, as they had a secondary composite outcome in the subset of patients with an ICH. And that secondary outcome, or that composite outcome, included in-hospital death, 30-day readmission, rebleeding on the 24-hour CT scan, and hematoma expansion. Unfortunately, the authors did not report out the differences amongst the composite outcome, but they did state that there was no difference in the incidence of that secondary composite outcome between the two groups. So as we see here, overall, there's no significant difference in time to SBP between clofidipine and nicardipine that we see here in patients with acute ischemic stroke as well as hemorrhagic strokes. However, there is one limitation in the sense of that these all included acute ischemic strokes. We know that time is tissue, and in our patients with acute ischemic stroke, we are rapidly trying to reduce the blood pressure in order for our patient to be a candidate for thrombolytic therapy. Therefore, we are ensuring that we're lowering the blood pressure to decrease our door-to-needle time. But the trial that we're going to talk about today only looks at ICH and SAH patients, particularly using nicardipine and clofidipine. So let's briefly talk about these two medications. These are two continuous infusion calcium channel blockers that are used for the acute blood pressure lowering. We use them in several different units, not just the neuro ICU. The biggest difference here is going to be the fluid volume that we get with nicardipine at its max rate of 15 milligrams per hour, resulting in a 75 ml per hour amount of fluid that the patient is receiving at that titration or at that max dose. And then the cost of these medications, depending on the pricing at each institution, is also something to look at. Historically, it's been said that clofidipine was more expensive than nicardipine, but again, it depends on your institution. And then the fast on, fast off profile of clofidipine, as a result of its rapid metabolism by blood esterases, is a unique aspect of using clofidipine, which is sometimes why this agent is used. However, we want to know, does the pharmacokinetic properties of clofidipine lead to a shorter time to the specific blood pressure goals that we have set in our hemorrhagic stroke patients, particularly when compared to nicardipine? So this is the question that this study aims to answer. So this was a single-centered retrospective trial that identified patients based on ICD-10 coding for either an ICH or a non-traumatic SAH that received either clofidipine or nicardipine. Patients had to be at least 18 years or older with a CT-confirmed diagnosis of hemorrhagic stroke. They excluded patients who had a traumatic ICH, If patients were receiving continuous IV antihypertensive medications that were not the two study drugs, or if the patient received the study drug for less than 1 hour in duration. They also had to have a 24-hour washout period between nicardipine and clofidipine because the investigators wanted to make sure that there was no confounding seen, as the half-life of nicardipine is longer than that of clofidipine. And then lastly, patients were excluded if they received dialysis during the hospital admission, as these drugs are renally excreted but not dialyzable. Therefore, investigators wanted to make sure that they were going to get consistent results, and we didn't see inconsistencies as far as the dosing goes in our dialysis versus non-dialysis patients, which is why these were excluded. The primary outcome was time to goal SBP from starting the infusion. And additionally, some secondary outcomes that this trial also looked at was the need for additional antihypertensive medications, the percent time at that blood pressure goal, all-cause mortality, 30-day readmission. They also looked at rebleeding on the CT scan at 24 hours. They also explored total time of the antihypertensive infusion, as well as hematoma expansion. And this was defined as a relative increase of greater than or equal to 33% or an absolute increase of 6 mLs in the hematoma size from the baseline to that follow-up CT scan. They looked at ICU and hospital length of stay. And then lastly, they also looked at the cost of each of these infusions at this institution. So let's look at some of these definitions. The percentage of time at SBP goal was determined by dividing the duration that the patients were at that SBP goal by the total time the patient was on the infusion, or that the infusion was running. The cost was calculated based on the number of bags that each of the patients used, and the cost at this particular institution for each of the concentrations of these agents are listed here on this slide. But as you can see, clofidipine was triple the price of nicardipine here. However, again, keeping in mind that this is going to vary based off of your institution's pricing. The ABC2 formula was utilized by providers to determine the size of the hematoma, and this was based on their imaging at baseline, as well as the follow-up CTs that they got. The image on the right is just a reference, just so that you guys can see how to calculate the ABC2 score or use that formula to calculate ICH volume if you are not, if you're not aware of how to do so. In this trial, investigators grouped patients into 3 different categories based off of their hematoma size. So patients were in the less than or equal to 10 ml group, the 11 to 60 ml group, or the greater than 60 ml group. Now let's look at what they used and how they titrated these infusions. Nicardipine was started at 5 milligrams per hour and titrated by 2.5 milligrams per hour every 5 minutes until they reached the blood pressure goal. Whereas clofidipine was started at 1 to 2 milligrams per hour, and that rate of the infusion was doubled every 90 seconds until the patient was close to their SBP goal. And then the rate was increased by less than double every 5 to 10 minutes until the patient was at their goal SBP. The target SBP goals for each of these patients was determined by the treating physician. However, in order to try to standardize the appropriateness of those goals, investigators classified the goals based off of the guideline recommendations per stroke type. So 183 patients were needed per group in order to reach 80% power to detect a 45% difference in the primary outcome. In order to combat the observational nature of this trial, the investigators utilized a 1-to-1 propensity score analysis to mimic a randomized experimental study without having the randomized study design. They also used a multilinear regression analysis in order to determine if there was a relationship between the time to SBP goal and different variables that could potentially influence that time to goal, such as age, race, stroke type, GCS, baseline SBP, or ICH volume. So 147 patients were screened for inclusion criteria, and of those, 58 of them were excluded. The most common reason for exclusion was an infusion duration of less than 1 hour of either of the study drugs. And then as we see here, the nicardipine group included 60 patients, whereas the clofidipine group included 29 patients. This is why that propensity score was utilized in order to reduce the bias of the unequal characteristics that they could have seen at baseline. So listed here is the baseline characteristics for the study group. In this first column, we have the characteristics listed. In this middle section, we have the frequency amongst the unmatched cohort of the baseline characteristics. So these are the raw numbers. This is the group where nicardipine has 60 patients and the clofidipine group has the 29 patients. And then all the way over here to the right in this section, we have the matched cohort population baseline information. So the two groups were similar at baseline amongst the unmatched cohort as well as the propensity score matched cohort, with the exception of a significant difference in the baseline SBPs between these two groups. As we see here, the baseline SBP was 170 in the nicardipine group versus 198 in the clofidipine group. However, when adjusted for those between group differences, there was no longer a significant difference seen in the SBP at baseline. Majority of these patients did have an ICH at baseline, with only about 3 to 5% of them having an unsurvivable hematoma size of greater than 60 mL. The median GCS was 13 in both groups. And then I did also want to point out the NIHSS was 3 in the nicardipine group versus 8 in the clofidipine group. However, these scores are missing for majority of the patients, or almost half of the patients in each of the groups. So keeping that in mind. Just like on the other slide, this is just a continuation of the baseline characteristics. Majority of these patients had a history of hypertension at baseline and were on blood pressure medications prior to their stroke occurring. 50% of these patients were either on anticoagulation or antiplatelet therapy at baseline. And then lastly, I do want to point out the duration of each of these infusions in this trial. So as we see in the unmatched cohort column, nicardipine ran for a median of 23 hours, whereas clofidipine ran for about 30 hours. So we'll keep that in mind whenever we're looking back at applying this to clinical practice later. So these next two slides are going to be a visualization of the distribution of blood pressure goals amongst the two different drug groups. So we have the goal blood pressures listed across the bottom on the x-axis, and then we have the number of patients on the y-axis. The dark yellow color here is a representation of patients that were in the nicardipine group, and the lighter yellow color are the patients who are in the clofidipine group. So this bar graph is a representation of patients who had an ICH only. And as we see here, majority of the patients had an SBP goal of less than 140 as per the guideline recommendations. On this slide, similar to the last one, the dark orange is going to represent the nicardipine group, and those that received clofidipine is going to be indicated in that lighter orange color. And these are in patients with subarachnoid hemorrhages. And as we see here, providers most commonly targeted an SBP goal of less than 130 or less than 140. Only about 2 patients with a subarachnoid hemorrhage were treated according to the guideline recommendations, targeting an SBP of less than 160. Now let's jump into the results of the primary outcome. So there was no significant difference between the nicardipine and clofidipine groups in the primary outcome of time to goal SBP. 30 minutes for the nicardipine group versus 45 minutes in the clofidipine group is the time that it took to reach goal, with a p-value of 0.73. However, after adjusting for the covariates and the propensity score matched cohort, that time to SBP remained unchanged and not statistically significant. And then when comparing the need for additional antihypertensive medications, there was no difference seen between these two groups. As expected, the nicardipine group did result in significantly higher total volume, almost 4 times higher the amount of volume that they saw in the when compared to the clofidipine group. And then as far as medication acquisition cost per infusion, it was significantly lower with the nicardipine compared to clofidipine, according to this institution's pricing, which we kind of saw whenever we were discussing the methods early on. But this institution, clofidipine was 5 times more expensive than nicardipine, according to their results. And there was no significant differences in any of the other secondary outcomes listed in the table. Hematoma expansion did occur in 17 versus 25% of patients in the nicardipine versus clofidipine groups, respectively. However, this was not found to be statistically significant. Looking at the absolute change and the relative hematoma change, as we see here, the hematoma size pretty much remained unchanged in both of the groups, or some of the hematomas actually got smaller, probably as a natural process of the brain reabsorbing the hematoma. And then as far as the results for the multilinear regression, looking for that correlation between goal SBP and those variables that we talked about before, there was no significant effect seen by any of those proposed variables, indicating that they were not highly correlated with each other. The R squared here was 0.179, indicating a poor fit for this poor model fit for this data set. So rebound hypertension did occur 50% less frequent with the nicardipine group compared to the clofidipine group. There was no significant difference in hypotension, severe hypotension, tachycardia, or AKI seen, and also no patients developed AFib in this trial. The authors concluded that in patients with hemorrhagic stroke, nicardipine appeared to have similar efficacy as clofidipine in SBP reduction, with less incidence of rebound hypertension and drug costs. So this trial was the first of its kind, studying the effectiveness of both of these medications in acutely lowering SBP in patients with hemorrhagic stroke, as well as looking at the hematoma expansion component. Similar to the previous 3 trials that we discussed earlier, there was no difference found between the 2 agents. And then interestingly, there was a trend towards faster SBP reduction in patients in the nicardipine group, which was opposite to what we previously saw. This could be secondary to the differences in the titration parameters across the different study protocols, or how the blood pressure was measured, a blood pressure cuff versus an arterial line. Or this could be due to the frequency of the blood pressure checks. In this trial, it was every 5 minutes, whereas one of the other trials we previously looked at, they monitored blood pressure every 1 hour. So again, it differs. So that could play a role. There was no correlation seen using the multivariable model. However, I do want to point out that at baseline, the clofidipine group did have a higher SBP and a higher NIHSS, indicating that these patients may have been of higher acuity. With that being said, the authors did attempt to limit the bias by utilizing that propensity score analysis between the 2 groups. However, this trial does lack generalizability. Majority of these patients were Caucasian, and majority of these patients had an ICH. They did not reach power, and the SBP goals did vary tremendously, but again, that was based on the treating physician. I would have liked to have seen more functional outcomes between the groups, as the functionality after stroke is the major factor that we consider when selecting appropriate therapeutic options for these patients. And I think that this trial solidified that either agent can be used in order to acutely lower blood pressure in the hemorrhagic stroke population. As we saw, there was no difference in time to goal SBP, but this trial did show a significant difference in fluid load as well as the medication acquisition cost, as we saw. We know that the max rate of nicardipine leads to about 75 mLs an hour versus 64 mLs an hour with clofidipine. So applying this to clinical practice, and also as we saw in this trial, most of the patients don't require a dose of 32 milligrams per hour of clofidipine. So I think volume is definitely something that we should be considering in these patients whenever we're trying to determine which agent we're going to use. And then I think institutional restrictions and pricing on these medications is the other piece that really drives us to use either agent over the other. So I think, again, that either agent is efficacious in this patient population, as we saw that there was no difference in hematoma expansion with similar time to goal SBP. Thank you so much for listening. And with that, I will take any questions.
Thank you so much, Taylor. Fascinating presentation, and thank you especially for the background, bringing us up to speed on this too. If anyone has questions, please post them in the chat section, or you can come off mute at this time. I did have a question for you, Taylor. With drug shortages being an endless feat for pharmacists and all of those caregivers that we work closely with, I do think it's really important that we become familiar with utilizing both of these agents, especially with our nursing colleagues. At your institution, do you use both of these agents? Do you use one preferably in a certain patient? And do you have order sets that are standardized between the two?
Yeah, so that's a great question. And this is actually something that I have definitely seen. So at my institution, we typically will reach for nicardipine first. And I think that's really just because of our familiarity with it. And however, we do see clofidipine sometimes. And so in those instances, it's mainly been in patients who we were worried about volume, and cost really isn't a huge factor here. Our clofidipine is actually only about $40 or $50 more expensive for our 100 ml vial compared to nicardipine. So cost isn't as much of a player here. We do have an order set, an antihypertensive order set that does have all of these titration parameters already built in. But I do agree with you in the sense of in drug shortages, as well as our nursing colleagues and having, you know, travel nurses who are trying to get used to how our system does it. I think that that is a huge player here. And I think that that potentially can drive whether or not you're going to reach your SBP goal based off of how you're titrating these meds. So I will say nicardipine is the one we mainly use, but we definitely use clofidipine as well in certain situations.
Thanks so much for that insight. Keaton Smetana asks, do you have any concerns of using clofidipine in patients on propofol? And assuming that this has to do with the lipid emulsion of either of these products and the potential combination of that being additive?
Yeah, that's a great question. And I would have to agree in the sense of, yes, that is definitely something that I'm considering. I think especially in like our COVID population, from what we've seen, these patients are requiring a lot of sedation as well as a good amount of propofol being used. And so triglycerides are definitely something that we're monitoring. And I think that propofol in conjunction with clofidipine is definitely something that I'm keeping in mind. And I would not, I probably wouldn't want to have clofidipine and propofol running together for a long period of time. And again, making sure we're monitoring those triglycerides every 72 hours or so. But again, it would really have to be a patient where either they were just resistant to nicardipine and it just didn't work for them, or a patient who we were really concerned about the fluid that we're getting from nicardipine. But if I could avoid it, I probably would, or just continue to monitor if I did end up with a patient on both.
Much, Taylor. And then we have one more question here in the chat, and it is, okay. What are your thoughts on using the primary outcome of % of time at goal SBP versus a more meaningful or patient important outcome such as functional outcomes? So if we had followed these patients longer, would you have assumed any difference there? Or is that more meaningful? And then also, if your institution carries both agents, how would you recommend a first line as being one over the other? And I think you've alluded to a little bit the second one.
Yeah, so as far as looking at time to SBP goal as a primary outcome, I think that I guess I understand where the authors were coming from and using that as a primary outcome. That has, as we saw in the other 3 retrospective studies that we looked at, that's kind of been the primary outcome that has historically been used. But I agree with, I would have liked to have seen the functionality outcome. However, looking at the hematoma expansion or lack thereof in this trial, I think that that's something else to consider, that even though we didn't have a functionality outcome as the primary endpoint here, we didn't really see, or there wasn't significant hematoma expansion. And I think that's the main thing that is going to drive the functionality outcome. So although I agree that, you know, that would have been a better outcome to have, I think also taking into consideration that they did look at that, and there wasn't a large difference between the two groups. And as far as what I would use or what I would recommend, and at my institution, our nurses are very much more comfortable with nicardipine versus clofidipine. So at my institution, I would recommend nicardipine over clofidipine for that particular reason. And like I said, I think titrating clofidipine is a little bit more difficult. So I would also take into consideration, like I, kind of alluded to in the back half of the PowerPoint, does this patient have an ART line, or are we waiting for a blood pressure cuff to cycle, every 2 minutes or so? That would make clofidipine very difficult to titrate. So these are kind of some of the things that I would keep in mind when recommending one agent over the other, but based off of familiarity, and I feel like that's the main driver in reaching your blood pressure goal is titrating these medications appropriately, I would recommend nicardipine over clofidipine.
Thanks so much, Taylor, and for that perspective of your institution and practice too. Let's round out with one last question, just because I think it's an important one, and I wonder if there was any evidence of this in the study you presented today. Andy asks, do you have any thoughts on blood pressure variability in intracranial hemorrhage, and if there are advantages with nicardipine or clofidipine for more consistent blood pressure control?
Yeah, that's a great question. So kind of, again, how in the middle or so of the PowerPoint, when we looked at the different SBP goals that they used here, we saw in ICH, they pretty much used a blood pressure goal of like less than 130 to less than 140. And it was honestly similar with the subarachnoid hemorrhage patients, which I think is appropriate based off of the literature that we do have. I think a blood pressure goal of less than 140 would reduce our risk of hematoma expansion and rebleed in both of those populations. And sorry, what was the back half of that question? I apologize.
That's okay. It's whether or not you think there would be an advantage to either of these agents with blood pressure variability and that more consistent blood pressure control.
Yeah, so again, I think as we saw here, we did see more rebound hypertension in the clofidipine group. So definitely keeping that in mind. However, in our patients who are going to hang out on nicardipine for a while, greater than, 4 days or so, 3 to 4 days, having nicardipine on for a longer amount of time can also, and as far as its like half-life or elimination half-life after on for longer, we can see more rebound hypertension and like with nicardipine in that sense as well. So I think as far as a more consistent management of the blood pressure goal, I think again, either one of them would probably suffice. But reaching more towards nicardipine, and especially hoping that we only have nicardipine on for a short amount of time, 12 to 24 hours after that initial rebleed. And then hopefully we're restarting either some oral agents or, titrating that drip down and getting them off of it, just so that we aren't getting to the point to where we will see rebound hypertension with nicardipine.
Excellent. Thanks again, Taylor. And thanks everyone who was able to tune in today for our Neurocritical Care Society Pharmacy Section Journal Club. You can engage on Twitter using the hashtag NCSPharmJC. And if you have any questions, you can still post them in the chat here, and we'll make sure to send them along to the presenters, and they can reach back out to you with any answers. Thank you all once again, and enjoy the rest of your week.